So, good afternoon, friends. So, today I'll be talking on this 10th journal update on COVID. So, I picked up two sort of an epidemiological studies or case series of patients with COVID. So far we have seen at least three to four descriptive studies of COVID-19 from Chinese. So right now the disease burden has moved to United States and Europe. So I picked up two papers, one on a descriptive study of all the COVID patients admitted in USA. The second study is of a descriptive nature of sick patients who were ventilated from Italy. So, so this is the first study. So this, as you see, is published just around a couple of days back. It's come in JAMA 22nd April 2020. So this is possibly one of the biggest descriptive study out of China that I could think of. It's a good study, so I would urge the listeners to go through this study because it has really dwelled into the depth of describing all the clinical characteristics patients present with. So the title of this article is Presenting Characteristics, Comorbidities and Outcome amongst 5,700 patients hospitalized with COVID in New York City area. So it's one of the possibly one of the biggest descriptive study. So this study, as you see, this is the map of the New York State. So this study is done in 12 hospitals in this New York State, predominantly in the New York City, Long Island, and Westchester area. So it encompassing 12 hospitals in this particular state. So this study was done between 1st March 2020 to 4th April 2020. So it's just a little about 1 month. So the outcomes they looked into this study was mainly the patients who were mechanically ventilated and description of the patients needing renal replacement therapy and the mortality. And these endpoints of outcomes was looked in 2,634 patients out of 5,700. So the total number of patients they looked in was 5,700, but they could look at these outcomes in 2,634 patients. So as you see, the total number of patients they have studied in this particular paper was 5,700 patients. So the median age, it is very important to again reiterate, the median age of the patients in this study was 63. Even if you look at Chinese study, we saw time and again it was the elderly people who are more vulnerable. And if you look at this interquartile range is 52 to 75. So somehow this disease seems to have little sparing effect on the younger population. Although initially we were hearing that younger people are affected in US, but I think this is a comprehensive paper. If you look at it, median age is 63 and interquartile range also is 52 to 75, which means to say again it tends to affect elder people more than the younger people. 39.7% are females. Again, you see this time and again that predominantly it is the males affected. Even from the Chinese data, we saw more than 50 to 60% were males. Even that remains the same even in this US experience, that around 60% males are affected and it is the lesser percentage females are affected. So when you look at the comorbidities in this particular paper, the predominant or the most prominent comorbidities that they found was hypertension. So 56.6%, that is 3,026 patients out of 5,000 odd patients were hypertensive. So again, this remained a commonality even in Chinese group, that hypertension somehow seems to be a common comorbid factor which tend to get affected. The second most comorbid in US study was obesity. And this also we have been hearing from the reports that obese patients tend to get more severely affected with COVID-19 patient. And 41.7% of the patients were obese, 1,737. And the third commonest comorbidity they found was diabetes. 33.8% were diabetics. So when you compare this with a Chinese study which gave a description of comorbidities, this came by Zhou et al. In Lancet. See here again you see hypertension was commonest, but it was 30%. So diabetics was 19%, coronary artery disease was 8%. So what this clearly shows is the US population seemed to have more comorbidities when compared to the Chinese description, because Chinese had the percentage of comorbidities was little lesser in Chinese. So again, which reiterates the severity factor of this disease in patients with comorbid problems, mainly hypertension, obesity and diabetes, and so is the case with Chinese. So it is very similar. So it's not very different. The way this virus is presenting globally seems to be similar to the Chinese pattern. So let's look into the symptoms. So the symptoms in this US description, 30.7% had fever and 76% of them had respiratory components. So they were tachypneic. So respiratory rate more than 24 per minute was present in 76 and 55%. So significant proportion of their patients who got hospitalized had dyspnea as a symptom, short of breath. So when you compare with the Chinese contemporaries, which this clinical spectrum was described in Huang et al., which came out in Lancet. Here 98% had fever, and if you see the percentage is far lesser in US group, and this we are seeing in our Indian population also. I think fever is not very commonly manifested, and as you see respiratory rate more than 24 or cough was present. So the other symptoms like the respiratory and dyspnea is very similar in US and Chinese population. So if you see the symptomology also appears to be very similar except that fever occurrence was low in US data. So post-discharge follow-up in this particular paper was looked at 4.4 days. So the patients were followed up for 4.4 days. Interquartile range was 2.2 to 9.3 days. And 2.2% of the patients in this US study needed readmission. And the readmission happened within 3 days after discharge. So that is something which we need to keep in mind, that even though patients get better, there was a small possibility of these patients getting readmitted. So which means there is a flaring up of the symptoms after discharge also in a very small subgroup of population. And the interquartile range for readmission duration was 1 to 4.5 days. And the median time for getting the PCR test report was 15.4 hours, which is pretty good. And the interquartile range was 7.8 to 24.3. So which means they could get the PCR report within a day, so which was pretty good. And same thing exists even in our country. Even in India, we get it within 24 hours. So let's now look into our ICU data, which is more relevant to all the listeners from intensive care community. So look at the percentage, 14.2% needed ICU admission of all the hospitalized patients, and this data is pretty similar to the Chinese also. Initially, the China data shows ICU admission was in single digit. Later, it kept increasing. So it's in double digit. So I will show the comparator data. So the median age who goes into ICU also was the older people. So as you see, the median age is 68 and interquartile range is 56 to 78. And this is pretty much we are seeing in India also similar data, that elderly people, at least in my state, Karnataka state, we are seeing more elderly people who are vulnerable to getting much sicker and needing ICU admission, and even mortality being higher. Even in Karnataka, I have reviewed the deaths in COVID, and all the deaths are above 60. In our 17 deaths that have happened so far in Karnataka, 16 deaths are above 60, and there is only one death which is above 55. So I think we are very similar to the world data. And 33.5% were females, which again tells you that the males are more common to go to ICU. And look at the intubation rate. So amongst the patients who go to ICU, 12.2% of them got intubated and mechanically ventilated. So around 320 patients got intubated, and this is a very alarming figure. Once they go on a ventilator, we saw from the Chinese data that the mortality was 97 to 98%. So is the case even in a well-developed country with a well-advanced ICU. The mortality was 88.1% in patients who got intubated. I think this is a very frightening number for us to keep in back of our mind. And when we compare to the Chinese data, this was the earlier paper which came on 15th Feb by Chen et al. Only 4% of hospitalized needed intubation and mechanical ventilation. But if you see the much later paper by Guan et al., which came in 28th Feb in NEJM, 14% needed mechanical ventilation. And so this is very comparable to the US data, where 12.2% got intubated and mechanically ventilated. And this is something new which Chinese data had not elucidated elaborately. 3.2% needed renal replacement therapy in the US population. And the mortality rate is in double digit. Once they go to ICU, this is ICU stats. There is a 21% mortality in patients who get admitted to ICU. So which again is a number that we need to be worried about. So as I said, 88.1% was the mortality in patients who get intubated and mechanically ventilated, which is worrying. And if you look at compared to the Chinese data, which came by Zhou et al. In Lancet 9th March, 97% of mechanically ventilated died, and ECMO all died. So this is a comparator. So again, going to reiterate, how much ever advanced is our ICU and our care, Once they go on mechanical ventilator, so the risk of dying is very high in the US data. So is the case in Chinese data. So that is where I urge the listeners to bear in mind that intubation is something, if in all possibility, we should try to delay if there is a way that you can bring them out without heading towards ventilation, for which I still subscribe to the fact that early recognition of symptoms and managing with more intense close monitoring and taking steps to prevent further worsening in respiratory status with supportive measures like maybe high flow nasal oxygen, maybe intermittent non-invasive ventilation if they are responding well, may be still the way to go, because the mortality once they go on ventilator seems to be really high, and that is worrying for us. So let us look into other details in mortality. Interestingly, this disease spares the young people. So as you see, 5,700 patients, less than 20 years, there is no death. Mortality is zero, which means this disease has a good sparing, it spares the young people. And males have higher mortality, which we have been seeing. So first of all, COVID-19 seems to affect males more than females, and even the risk of males going to ICU is more, and mortality in males also is high. And this higher mortality in males was seen at every 10-year age interval after 20 years. After 20 years, if you take every 10-year interval, males always had higher mortality than females, which again is worrying for male gender. So as I said, mortality was 88.1% in mechanically ventilated, which means 282 patients died who went on ventilator. So then they stratified between the ages. So they divided into two groups, 18 to 65 and more than 65. Again, you see 18 to 65 mortality is 76.4. If it is more than 65, mortality is like Chinese, which is 97%. Which means time and again you are seeing from the data coming worldwide that more than 60 become extremely vulnerable, and once they go on ventilator, God only save them, because the risk of dying is very very high after 60. And if you see more than 65, 97, this is from US data, where we we sort of believe that best care and advanced healthcare measures would be available. And in this same age group, if 18 to 65 they are not mechanically ventilated, mortality was 19.8. More than 65, even if they are not mechanically ventilated, mortality was higher than the other group, 26.6%. So length of stay for all these COVID patients in ICU was 4.1 days. Interquartal range was 2.3 to 6.8 days. And another feature the authors highlight is diabetics also tended to have higher mortality, most importantly higher risk of AKI. So that's the subgroup of population which had a higher risk of AKI. So this is another interesting subgroup analysis they did, where they looked at the ACE inhibitor. So 2,411 patients they looked for drug history, and they got drug history for 189 patients who are on ACE inhibitor, 7.8%. 11.1% were on ARB, angiotensin receptor blocker, and no ACE were rest of the patients, and they saw mortality to be higher. Again, there was a hypothesis saying patients who are on ACE inhibitors have higher mortality. This observation was established, was seen, and was discussed in our scientific circles. But ACCP, American College of Chest Physicians or Cardiology Society, came out with their guidelines saying we don't need to stop ACE inhibitors in patients who are already on. But this study again reiterates that patients who are already on ACE and ARB, mortality was higher. And the authors again hypothesized that these patients possibly expressed more ACE receptor expression, which led to more severity of their condition. Again, this needs to be evaluated in further trials to see whether this has a bearing on their outcome. So authors do leave it at that. So this is something we need to bear in. Someone in ACE inhibitors or ARB, they tend to have a higher mortality. Okay. So that's a cartoon you might have seen making rounds in WhatsApp. So that's about the US study. So in summary, the US study data is very similar to all the Chinese data that have come. So the key messages is elderly are more vulnerable. Elderly with comorbids are even more vulnerable, more so with hypertension, obesity, and diabetics. So diabetics have a higher risk of AKI, and once they go on mechanical ventilator, the mortality is about 88 to 90%. And when elderly more than 65 go on a mechanical ventilator, mortality hits close to 98%, 97 to 98%. So this is a message which has resonated from the Chinese study also, and the same thing has been subscribed to by American study also. So there's no further debates, and even this similar pattern we have seen in India, more so in my Karnataka state, I have seen a similar pattern. So there is no further room for sort of a non-clarity that younger people are more severely affected, because looks like world data suggests that elderly are more vulnerable and the severity also tends to be more. And another thing that we saw in US is less than 20 no deaths, so it seems to be very sparing the younger population. So now let's look into the Italian study. So this particular study came as you see, it's an ahead of print by Zangrilla et al. So this is an interesting study which predominantly looks in intubated and mechanically ventilated patients, which is very pertinent to our ICU. So the title is Characteristics, Treatment, Outcome and Cause of Death of Invasively Ventilated Patients with COVID in Milan, Italy. We know Lombardy area where Milan comes is most severely affected. So this journal is to be published in Critical Care and Resuscitation. So they took 73 patients who were intubated and mechanically ventilated. So they took sickest of the patients and tried to characterize the description of the patients. So the study was done between 20th Feb and 2nd April 2020. Again you see, so there you saw 60% plus were males. Here 83.6% of their patients were male who ended up on ventilator. So I think for male gender, so the COVID seems to be a really bad news, that it tends to affect males more severely, and and males tend to go on ventilator more commonly than females, and mortality is higher in males. So that's what seems to be coming time and again from the data we see. So males have to be more careful. So the median age is 61 years. Again, you see 60. 60 seems to be a ballpark age. After 60, I think the vulnerability factor tends to really go up. So as you see, the interquartile range is very similar to US. 54 to 69 is the interquartile range. Again, you see hypertension is a commonest risk factor. 52.9, more than half of the patients were hypertensive even in Italian group. And interestingly, in Italian group, and this also we saw from Chinese data, 73.3% of them who ended up on ventilator had lymphopenia. Again, this has been typically described from the Chinese data. And they looked at these markers, which are all previously described in Chinese trials as indicators of poor outcome. CRP was high in these ventilated patients, 184. This is the interquartile range. D-dimer was high. We saw in Chinese data that D-dimer was an independent predictor of odds of dying up to 6.2 or something was the odds ratio. Even here D-dimer was high. The 10.1 was the value, and this is the interquartile range. And this is important message I want to give. See, there is a lot of discussion happening on two variants of ARDS that is prevailing. So one variant with a normal compliance, one with a low compliance, and what is the tidal volumes that we should be using for normal and all that. But if you see this Chinese comprehensive data, 73 patients, they've used low tidal volume. So this is the median tidal volume they used for 73 patients, 6.7. And even if you look at interquartile range, they have not used high tidal volume at all, 6 to 7.5 ml. So which means they have subscribed to or adhere to the ARTSNet trial, ARTSNet protocol pretty much for all their intubated patients. And this is also a very important message. So although we have said that high compliance, they did not use high PEEP, and low compliance patients, it was the lungs were recruitable, say they used high PEEP. But if you look at the at least the published data, you see the median PEEP they used was 12 centimeter, which means that they have used high PEEP for predominantly all their patients, and the interquartile range is 10 to 14. So most of their patients, 73 patients, they have used proper ARTSNet with a high PEEP, at least if I have to subscribe to the data that they have published, isn't it? And 63.8% were prone in this Italian study, and 6.8% of the patients, or 5 patients in the study, went on an ECMO. So the median follow-up was better than America. They followed up for only 4.4 days, maybe because of their urgency to publish the data to help the cause of COVID and to help other people to understand the nature of the disease. Here they followed up for 19 days. So interquartile range was 15 to 27 days. So the mortality, so this is interesting. You have to see this is intubated and mechanically ventilated. From Chinese data, we saw mortality is 97%. In US data, you saw 88. But here, if you see, you may think that Italians have done remarkably, but the case is not so, because mortality is 23.3%. 31.5% got discharged, 23 patients, which is very good. I think they have done well with their mechanical ventilation. But the third column, third row, what you see, 45.2% were still on ventilator when they published the study, which means to say we don't know about their outcome. So if you take their outcome, it I mean, for all, in all likelihood, this mortality would at least double up, I would think. So it would touch 50%. So whatever said and done, mortality in ventilated patients touches 50 to 60% by the looks of it. But this is a incomplete data because still there are uh, nearly half of the patients were still ventilated. So we cannot subscribe to saying that they had a low mortality ventilated. So that is a message I want to say. And here they look for odds for death again, which again corroborates to our Chinese data. The age. See, if you looked at Chinese data by which was published in Lancet, they said old age was a odds independent risk factor for mortality so far. Sequential organ failure and D-dimer. These are the three variables they had done a multivariate regression and looked at as a predictors of mortality. Here, old age is one of the marker and hypertension. So the odds ratio was 6.15. That was statistically. Again, this resonates and aligns to what the US data showed. So if someone is hypertensive, the odds of death when they go on a ventilator. So the odds of them going on a ventilator is high. The odds of them going to ICU is high. The odds of them getting COVID is high, and the odds of them having mortality also is high. So which is very disturbing for us because hypertension is a common condition which many of the elderly people would have, and this is a worrying trend. But interestingly, what they found is early improvement. This is also an important indicator that we need to keep in mind. Early improvement in PaO2, FiO2 was associated with improved survival, which is quite intuitive because if someone has had an early improvement in PaO2, FiO2, what it means is their lungs are recruitable early and they are responding to the lung protective strategy that you have adopted and they are getting better. So if lungs are not recruitable, then your PaO2, FiO2 would not improve. So the mortality was higher, and that was shown graphically. So complications. So this is quite alarming in this study. If you saw the US data, AKI was very less, but this is on a ventilated patient. So if someone gets on a ventilator, the risk of AKI was 75.3% in this particular Italian group. Means once they go on ventilator, the AKI risk we can subscribe to as being very high, and secondary bacteremia occurred in 9.6%. So this is a graphical representation of early improvement in PaO2 by FiO2. So you see the blue line is all survivors, red line is non-survivors, and blue is this is the improvement in PaO2 FiO2. See, if you see there is an early improvement in PaO2 FiO2 who survived, but if you see the red, they did not have an early improvement in PaO2 by FiO2. And this was looked at discharged patients and not discharged. So the blue one is discharged. So if they looked at the discharged patient, you see there was an early improvement in PaO2, FiO2. The red one is people who are not discharged, means who are not getting better, who are intubated. Obviously, their PaO2, FiO2 is not improved. So this is a good graphical representation. When you intubate a patient with COVID, if there is no improvement in oxygenation, that is a worrying trend. That in all likelihood they may die. But if PaO2, FiO2 starts improving with your whatever lung protective measures, then you can reconcile that the outcome may be better and they may do well. So this is all about these two studies. They're more like a case series. So how much ever you read the paper, this is the core essence of the information that you can get from these two papers. There are a lot of tables in the JAMA paper and even in this paper. But how much ever you read, I think the core essence of these two papers is what I have just narrated. So hope this will be useful for us to understand. So at least I can say in Karnataka, where I am doing rounds for 6 district hospitals, we are seeing a similar trend. All elderly patients more than 60 are the ones who have died so far. As I said, in 17 patients as of 24th April who have died, 16 are above 60 years. And these are the patients who tend to go to ICU, and they are the patients who have comorbids, and the patients who have died predominantly have had multiple comorbidities, have had diabetes, have had hypertension, many of them have had a lung diseases. So this is what seems to be a recurring pattern worldwide. So there's so there should not be any sort of a non-clarity with regards to the patient profiling, because it seems to be very similar from what came up from Chinese data, and they seem to concur with the data that is coming from US, from Italy, and the similar trends is what we are seeing, at least in my state, in India. So thank you very much. So I'll end my talk with this cartoon. I'm sure many of you have seen. It's a good cartoon. So right now there are multiple treatments, around 15 drugs proposed, but conclusively there has been no magical therapy for COVID. So as of now, the therapy predominantly remains very supportive. So early identification, early recognition of alarms, and good monitoring and saturation, early picking up of hypoxemia and addressing hypoxemia and preventing further down spiral definitely can save lives. So our message would be to pick up the patients early, monitor them more aggressively for ongoing hypoxemia, and support them with good sort of ancillary support measures like oxygenation and good spirometries and all the housekeeping measures. I think this would be the life saving. And as we all know, 15% are hospitalized. So our whole effort from our intensive care community is to prevent this 15% to go into ICU. Even if they go into ICU, all our efforts would be to try and avoid them to going on invasive mechanical ventilation. So good oxygen therapy hopefully may succeed in preventing them from going to a intubation and mechanical ventilation. So thank you very much.